Hello, everyone. Happy afternoon, a very good afternoon. I hope and I believe all of you are doing well. A quick note, everyone. Am I audible and visible, everyone? Hi, happy afternoon, everyone. And I can read your comments in the live chat. See, it's absolutely fine. आज किसी का दिन कल किसी और का दिन, so it's absolutely fine. Just our work is to put in our best efforts, right? We would see the results soon, maybe not today, but tomorrow, right? That's the learning lesson there. Yes, mnemonics. Yeah. So my work is whether I have 10 viewers or 100 or thousands or 10,000, how many number of viewers, each one of you is important for me. And the efforts that I put in will not change or will not depend on the number of viewers who are here, right? So it's always going to be the best of the efforts, which is going to be there so that, every minute that you spent with me in a live class or a recorded video is worth watching it. That is what is the whole purpose. Is this useful for NEET PG? Absolutely, yes. Please understand that FMG and NEET PG syllabus is not different. And especially in the recent years, right, you can see the level is also becoming almost the same. So yes, it's very, very important. Right. So I know whoever is here, and especially if you are appearing for the upcoming FMG exam, which is in next 2 days, I can understand and I can totally feel that how anxious you must be कि कैसे होगा, क्या होगा, होगा कि नहीं होगा. My only thing, just remember is whatever efforts you have put in, that will definitely show the results. Just have the faith. Please do not do this mistake that the last minute anxiety and panic affecting your performance. And even in the exam hall, no matter, even if initially the paper seems very difficult, have the faith, the questions which are going to come further are going to be easy and solvable, right? And very important for FMG exam, because you have exam in part A and then you have a break in part B. So do not let the performance of part A affect the performance of part B, right? Take them as two different exams, not carrying the baggage of the part A. Very, very important. Do not let it affect the performance of part B. And trust me, cracking FMG is going to be easy, right? Just have the faith in the efforts that you have put, right? And understand everything has been so good so far, so abhi bhi sab acha hi hoga. So just have that faith. Okay? Yes. User, thank you so much. I would be waiting to hear from you post exam, post results. Right, your success is my success for sure. Okay, so without any further delay, without taking much of your time, guys, let's start with the today's session. I'll be sharing the PDF as well, right, with you, both blank and annotated. It will be available in the MedSynapse app, the free content one. Right, Final Punch करके एक folder है जिसमें already 8 videos हैं. So for the last minute revision, you can also revise those videos. And apart from that, I'll be adding this video as June 26 FMG final punch, and you will have both the blank and annotated PDF available there. Right, the link of also is given in this PDF. Okay, how many questions we can expect from this session? I am expecting like at least 10 questions to इसमें से आ जाए. Let's see. Okay. All right, let's start. So we have some different formats today that we are going to discuss. These are all very, very important topics, extremely important. I've tried to add images also wherever it is relevant. So first one, what adult structure is derived from the embryonic notochord? So first of all, this image-based question can come in the exam. Understand that this is what is the notochord here. In front of that, which has a hollow thing, that's a neural tube, and lateral to the neural tube, ऐसे जो paired वाले दिख रहे हैं structures, those are the neural crest cells. Okay, is this clear with everyone? Very, very important. This is neural crest, this is notochord, and this is neural tube. And adjacent to that, you have the somites present here. Paraaxial mesoderm somites आएगा, और ये वाली जो layer है यहाँ पे, this is the ectoderm. Okay, so this is the notochord. Remember, notochord remnant is nucleus pulposus. Okay, notochord remnant is nucleus pulposus. And the tumor from notochord, chord is chordoma. What tumor do you have from the remnants of notochord? That is chordoma. Going to next one, if this fracture is given, right? This is, what bone is this? This is tibia, this is fibula. So there is fibula neck fracture. What nerve injury comes here? Very, very important. That is common peroneal nerve. And when there is common peroneal nerve injury, the patient will present with foot drop. What is the function of peroneal nerve, guys? What is the trick, the mnemonic to remember that? What is the function of peroneal nerve? Inversion, plantar flexion, inversion, dorsiflexion, eversion, plantar flexion, eversion, dorsiflexion. What is the function of peroneal nerve? Yes. So please remember the mnemonic, very, very important, which is speed, tip. Okay, remember the mnemonic PED tip. What is PED tip? Peroneal nerve is responsible for eversion and dorsiflexion. Tibial nerve is for inversion and plantar flexion. Okay, will you remember this? Very, very important. So when there is a peroneal nerve injury, the dorsiflexion will not happen. So there's going to be foot drop. Okay, and can someone tell me what is wrist drop due to? Foot drop is common peroneal nerve. Wrist drop is what nerve? Remember mnemonic, doctor drop is caused by radial nerve. Okay, Dr. Kuma, that's our mnemonic in the upper limb. So remember, that is radial nerve causing wrist drop. Okay, very good. What syndrome involves damage to the cranial nerves 3, 4, 6 and ophthalmic nerve? Remember 3, 4, 6 supplying the extraocular muscles, ophthalmic nerve again related to the eye. So that is superior orbital fissure syndrome. Remember, very, very important, superior orbital fissure. You have 3, 4, 6 and 5, 1 going through it in the superior orbital fissure. Which nerve will not be involved in superior orbital fissure? The second cranial nerve. The optic nerve will not be involved. Please remember that. It will be involved in, the optic nerve goes through the orbital apex. Okay, that will be involved in orbital apex syndrome. Okay, orbital apex syndrome. Is this clear with everyone? So let's have a look at these foramen. The skull foramen, one question generally comes in exam. This is at the junction of the lesser and greater wing, where you have the superior orbital fissure. Remember, the mnemonic for the foramen is frost. सबसे पहले होता है fissure. फिर क्या आता है वहां पे? foramen rotundum. Then you have FROS. So this is rotundum, ovale, and this is spinosum. And this is the fissure here. So frost, that is how it goes from anterior to posterior. So the large foramen, oval foramen that you see there, that is the foramen ovale. Okay. What goes through foramen ovale? Remember, ovale is male, that is man. That's going to be mandibular nerve. Okay, that's going to be mandibular nerve. So trigeminal mein you have ophthalmic, maxillary, mandibular. So remember, maxillary nerve goes through maxi. A girl wearing maxi rotating. Rotating is rotundum. So rotundum is maxillary nerve. Ovale is mandibular nerve. Okay. Going to next one. What vessel is there in the anterior interventricular groove? Remember, anterior matlab anterior. The left anterior descending artery. LAD is what goes in the anterior interventricular groove. Can somebody tell me what vein goes with it? What vein goes through it? I'm sorry, I forgot to share the PDF before the session. I'm sharing the PDF right away, guys, on my Telegram group, Telegram channel. So if you want, you can get it from there. Yes, so I've shared the PDF on my Telegram channel, Telegram group. Okay. Let me. I'm putting the link from where you can get the PDF directly from there. Right. So I've pinned the message in the live chat for the PDF link. You can get it from there. Okay. So remember, along with the LED, left anterior descending, what goes is the great cardiac vein. Very, very important. So how do you remember? Great people are always in the front. Great veins are in the front anteriorly. So great cardiac vein. We have discussed entire cardiac, the coronary circulation with tricks in our short videos on app. Which nerve provides sensory supply to the skin of the chin and the lower lip? Remember, यहाँ पे chin मतलब कौन सा region है? Mental region. So that is mental nerve. Versus what nerve is the sensory supply for this angle of the jaw, angle of mandible? Angle of mandible is what nerve? Very, very important. If there is sensory loss here, angle of jaw, angle of mandible, that is greater auricular nerve. Okay, remember that is greater auricular nerve. C2, C3 is at roots value. Okay, very, very important. Going to next one, what muscles cause the abduction of the fingers? Remember the mnemonic pad and dab. It is dorsal interossei abduction, palmar interossei adduction, and remember all interossei. They are supplied by what nerve? The mnemonic is interossei or unterossei. Remember it like that. So all interossei are unterossei. That means they are supplied by ulnar nerve. How do you identify dorsal and palmar interossei from the image? First of all, interossei in between the bones. They arise from the bones, the metacarpal. So if you look at the image here, if these muscles are bipinnate muscles, they are dorsal interossei. Remember, dorsal is do matlab bi. So they are bipinnate muscles that you can see. Palmar interossei, they are unipinnate muscles. Okay, palmar interossei. Remember, these are not the lumbricals. Lumbricals you identify as arising from the tendon. Okay, if they're arising from the tendon of FDP, that is lumbricals. If not, right, then they are these palmar interossei muscles. Okay, clear with everyone? So tendon से आ रहा है तो lumbrical muscles होंगे. Next one that you have here is, which muscle is pierced by musculocutaneous nerve? Musculocutaneous nerve pierces this muscle, which is this coracoid process से जो आ रहा है, coracobrachialis muscle. This is coracobrachialis. Musculocutaneous nerve is piercing that. Okay, so it is piercing the coracobrachialis, and musculocutaneous supplies what muscles? BBC muscles. What is BBC? Biceps, brachialis, and coracobrachialis. Remember, it is not brachioradialis. Brachioradialis is in the forearm. It is supplied by the radial nerve, not the musculocutaneous nerve. Okay? So musculocutaneous nerve is going to be coracobrachialis. It pierces coracobrachialis. Going to next one, this Trendelenburg sign. What nerve are you testing here? Remember, it is superior, not the inferior gluteal nerve, which supplies the abductors of the hip. That is gluteus, medius, and minimus. Not maximus is the extensor. Okay. So in this image, which side is abnormal? The right side or left side? If you look at the image here, you are looking at the patient from behind. This is right side. This is left side. So on which side the patient is standing? The right side the patient is standing. AN, ABN abnormal. This side is dropping. Left side is dropping. The opposite side drops. Okay. Is this clear with everyone? So remember, it is going to be the right superior gluteal nerve which is abnormal here. This is for the abductors of the hip. Going to next one, the major extensor of the hip. Remember, X is X, that is maximus is the extensor. And maximus, naam bada darshan chota, it is supplied by inferior gluteal nerve, not the superior gluteal nerve. Okay. So this is very important image, frequently asked in exam. Identify what muscle it is. The muscle which is arising, which has this origin from the sacrum as well, that is the gluteus maximus. The one which is from this, the iliac crest wala, that is the gluteus medius. And then you have jo beech mein se aa raha hai, not from this edge, that is going to be the deepest muscle, that is gluteus minimus. Okay. So maximus, remember, there is origin from the sacrum as well. That is how you identify maximus. Okay. And maximus is not inserted on greater trochanter. These two, they go on the greater trochanter. Okay. Going to next one, the nerve and the only muscle associated with third pharyngeal arch. Third pharyngeal arch का nerve कौन सा है? Remember 3 का होता है 3 square. That is the ninth nerve, the glossopharyngeal nerve. 9 का reverse, if you look at the mirror image, that is P. So remember, it is stylopharyngeus muscle, not stylohyoid or styloglossus. It is stylopharyngeus, which is the only muscle of the third arch. Is this clear with everyone? Yes. Median nerve in the brachial plexus is arising from what cords? Remember, median is like in the middle, right? It is neither medial nor lateral. That means it is getting contribution from both. That is how you remember. So lateral and medial cords. So which nerve in the brachial plexus has contribution from two cords? That is the median nerve. It is beach ka, lateral and medial both contributing. What pollicis muscle is supplied by ulnar nerve? The pollicis muscle here. यहाँ पे आता है median nerve, but there is one pollicis muscle which is ulnar nerve. Remember, adductor, which is going towards the ulna. So that is ulnar nerve. So remember, it is adductor pollicis which is supplied by ulnar nerve, and it is tested by the book test or the Froment sign. So right, this is abnormal. If you see the flexion happening, that means the adduction is abnormal. So the book test, Froment sign, that is basically for ulnar nerve. Okay, remember, that's for ulnar nerve. Then you have what layer is not present in esophagus? Remember, esophagus does not have a serosa. And which heart chamber enlargement causes esophageal compression? So if you remember the cross-sectional image, CT image of the heart is like this. Here comes the vertebra and here comes the esophagus. So close to the esophagus is this posterior most chamber, which is the left atrium. So left atrium is what is related to the esophagus. It is left atrial enlargement. Coming to joint, what is the growth plate ka joint between epiphysis and diaphysis? Remember, that is the cartilage. What cartilaginous joint? Primary or secondary? Primary. There is no movement happening there. Secondary वाले में थोड़ा movement होता है. So it is primary cartilaginous joint which is called as synchondrosis. Chondro मतलब cartilage. Okay. And what is the joint between malleus incus and incus stapes? Remember, malleus incus and incus stapes. MI is a sad event in anybody's life. Getting a MI is sad. So it is saddle joint. ISS is, this is the mnemonic for ball and socket joint. Okay, remember this. That is TCN, talocalcaneonavicular, hip joint, incudostapedial joint, shoulder joint. These are ball and socket joint. Okay, all your tricks of types of joints has been discussed in short. Please revise it. One question on type of joint is very frequently asked in the exam. Okay. Going to next one, the left recurrent laryngeal nerve loops around which structure? Which recurrent laryngeal nerve is longer, the right or the left? Remember, left, L for L, is longer. It goes down, it loops around the ductus arteriosus, arch of aorta, ductus arteriosus, and that is why it is longer. The right one, it loops around the right subclavian artery. The left is around the arch of aorta, ductus arteriosus. So this ductus arteriosus is derived from what aortic arch? Remember, very important question. This is left sixth aortic arch, asked frequently. Ductus arteriosus, ये ductus का D, इसको हम उल्टा करेंगे, this will become sixth. So it is left sixth, not the right sixth. This is where you can see the ductus arteriosus. It is the duct connecting the two arteries, pulmonary and aorta. In which congenital infection do you get patent ductus arteriosus? Patent ductus arteriosus is seen in what? Congenital syphilis, rubella, CMV, toxo. Where do you see patent ductus arteriosus? Hi Prakash, great to hear from you after a long time. I very vividly remember you misreading your name always as Prakash instead of Prakash. I hope your residency is going well. Yes, very good. That is congenital rubella. Congenital rubella has patent ductus arteriosus. Great. What muscle of mastication opens the jaw? Opens the jaw means lowers the jaw. Remember, L for L. That is lateral pterygoid. Okay, lateral pterygoid. How do you identify lateral pterygoid from the image? It goes into this TM joint का disc. वहाँ पे insertion होता है. So related to the TM joint is going to be this lateral pterygoid muscle. So only muscle opening the jaw, lateral pterygoid, lowers the jaw. Okay, very, very important. What is the epithelial lining of trachea? Remember, trachea is going to be ciliated epithelium. It is PSCC, pseudo-stratified columnar epitheliated columnar epithelium. Okay, pseudo-stratified ciliated columnar epithelium. What epithelium you have in urinary bladder? Yes, urinary bladder is going to be transitional epithelium. Okay, that is transitional epithelium. In HNPCC, what defect is there? What DNA repair defect is there? Very, very important. Remember, it is mismatch repair. Versus in xeroderma pigmentosa, it is what repair? Remember, X is like NEX. Okay, so NE, it is nucleotide excision repair, not the base excision repair. Okay, remember, X is NEX. That is nucleotide excision repair defect is what you have in xeroderma pigmentosa. In infants with which this deficiency, the galliput, that is galactose 1-phosphate uridyl transferase, that basically leads to galactosemia. Classically, you would see cataract. What cataract? Oil drop cataract. Okay, this is classical galactosemia. And the enzyme deficient is galliput. Okay, very, very important. Which vitamin deficiency can lead to lactic acidosis because it is affecting the pyruvate conversion? Remember, thymine deficiency, because pyruvate dehydrogenase requires thymine. Plus, what does it require? What are the 5 things required by this enzyme? Remember, TLC-FN, tender loving care for ninjas. Okay, Nikita's ninjas. TLC, thymine, that is B1. L for lipoic acid, C for coenzyme A, F for FAD, N for NAD, NADH. So this is basically vitamin B2, riboflavin. This is vitamin B3. Okay, that is niacin. So you have TLCFN, which is required by this enzyme. In Marfan syndrome, what protein is defective? It is fibrillin 1. Okay, it is fibrillin 1, which is defective in Marfan syndrome, which is what chromosome? Fibrillin FI. Remember, it is chromosome 15. Fibrillin, Marfan is autosomal dominant, right? What is the major intracellular antioxidant which is responsible for detoxifying the free radicals? Remember, intracellular, you have glutathione. Okay, glutathione, free radical scavenger. Which enzyme is deficient in Pompey's disease? Glycogen storage disorder. One question, very, very important. Pompey's, remember, affects the pump of the body, that is the heart. So the clinical presentation is cardiomegaly, cardiac failure. And remember, heart uses fatty acid. So acid maltase. Okay, that is acid maltase, also called as alpha glucosidase. This is the glycogen storage disorder, which is lysosomal, because this enzyme is lysosomal enzyme. So this is lysosomal storage disorder. In Lesch-Nyhan syndrome, what is the inheritance pattern? Lesch-Nyhan, remember, is X-linked recessive, and the enzyme is HGPRT. It is not just deficient, it is completely absent, HGPRTase. Okay, HGPRTase is an enzyme of what pathway? So Lesch-Nyhan is a defect in what pathway? Yes. करेक्ट रागिनी, एंजल मेंस भी 15 पे आता है. रिमेंबर 15 का फैमिली वाला निमोनिक है. मदर, फादर, सन एंड डॉटर. मदर इज द एंजल, एंजल मैन. फादर पैटर्नल प्रेडोविलाई. Tall son is Marfan. Fair daughter is albinism. So albinism is also chromosome 15. Okay. Yes. Can somebody tell me this HGPRTase is what enzyme is with cycle? This is purine salvage pathway. Okay, this is purine salvage pathway. So in Lesch-Nyhan, remember, there's going to be increased uric acid features as well. Classically, the question gives self-mutilating behavior, which is seen, very, very important. Okay. Wilson is what gene? Remember, ATP7B, not 7A. Remember, Wilson, son is beta, that's going to be ATP7B. ATP7A is Menkes disease. Okay, Wilson is copper excess and Menkes is copper deficiency. It is X-linked. Menke has kinky, kinked hair is present. and the enzyme deficient is lysyl oxidase. Okay. What is the function of hepcidin in iron metabolism? Remember, hepcidin is the acute phase positive acute phase reactant. And what does hepcidin do is the iron which is coming into the circulation, it inhibits there by inhibiting ferroportin. Ferroportin, which is taking the iron into the circulation from intestinal cells, reticuloendothelial cells, वहाँ पे उसको prevent करता है. So it inhibits ferroportin. Right. And what happens in primary hemochromatosis? Hereditary or primary hemochromatosis has hepcidin excess or hepcidin deficiency. Remember, it is hepcidin deficiency. Okay, hepcidin deficiency. So there's a lot of iron coming into the body. Then you have vitamin B12. Where is it absorbed? Vitamin B12. Remember, it's not absorbed in the jejunum but in the ileum. What else is absorbed in the ileum is the bile acids. So remember BB, B12 and bile acids. Then the deficiency increases methylmalonic acid. Very, very important. MMA increases in vitamin B12 deficiency. Right? So remember MMA, methylmalonic acid, increases in methylcobalamin deficiency. Methyl. What is the other finding which differentiates B12 deficiency from folic acid deficiency? The B12 also causes neurological manifestations like subacute combined degeneration of cord, which classically affects what pathways? Very, very important in the spinal cord. It affects the dorsal columns in the spinal cord. Okay, that is why there's loss of proprioception, vibration, which you see in B12 deficiency. Right, after gastrectomy, B12 becomes low because intrinsic factor is not coming. Going to next one, which pathway is affected in G6PD deficiency? Remember Gundeche, G6 or Hum5. HMP is like Hum5. इसका rate limiting enzyme है G6PD. So G6PD deficiency, remember, is X-linked recessive and it presents as hemolytic anemia, especially with oxidative stress. Wherever there is oxidative stress, like patient on malaria treatment because you are giving primaquine, right? Patient eating fava beans, uske baad ho raha hai hemolysis, it is G6PD deficiency. So it presents as episodic hemolytic anemia. Okay, episodic. How does alcohol consumption lead to hypoglycemia? Remember, alcohol inhibits gluconeogenesis basically by increasing the NADH-NAD ratio. Okay, it increases the NADH-NAD ratio, inhibiting gluconeogenesis. What accumulates in Zellweger? Remember, do not confuse Zellweger with Refsum's disease. Zellweger, when you say A to Z, so imagine like A to Z, Z is at the last very long chain of alphabets. So this is going to be very long chain fatty acid accumulation. Versus what accumulates in Refsums? Remember, in Refsums, it is phytanic acid accumulation. Okay, phytanic acid accumulation. Okay? Refsums has this RERE, retinitis pigmentosa, is seen in Refsums. Correct. PEGS gene, peroxisome wala, absolutely. These are basically your peroxisomal wale disorders. What receptors are involved in myasthenia gravis? Remember the nicotinic receptors, neuromuscular junction wala NM receptors, which are post-synaptic, not pre-synaptic, right? So there is this acetylcholine receptor autoantibodies which are present in myasthenia gravis. Classically in myasthenia gravis, there is fatigue, which increases with exertion, with activity. There is fatigue, there is ptosis, which is more in the evening, right? Malignant hyperthermia is what receptor defect? It is ryanodine receptor. Ryanodine receptor defective, leading to a lot of calcium, a lot of muscle contraction. So a lot of heat generating malignant hyperthermia. What do you give in the treatment? It is dentrolin. Okay, dentrolin is given in treatment. Then you have which transporter mediates a facilitated diffusion of glucose in muscle and fat? So remember, muscle, fat, skeletal muscle, it is insulin dependent, GLUT4. Remember insulin. 4. Insulin for GLUT4. Insulin is required for GLUT4. So insulin dependent is GLUT4. It is important in muscle, adipose tissue and skeletal muscle. Okay, adipose skeletal muscle, you have GLUT4. What is the classical clinical triad in Cushing's reflex? Where do you see Cushing's reflex and what is the triad of Cushing's reflex? Yes? Yeah. Very good. Raised ICT. Okay, so raised ICT. So when there is raised ICT, the body will compensate by increasing the blood pressure further so that the blood flow to the brain can happen. If this is the raised ICT, the blood pressure has to be more than that. So that will cause hypertension. एंड रिमेंबर दैट बैरोरिसेप्टर जब हाइपरटेंशन होगा तो रिफ्लेक्स जो होगा वो होगा ब्रैडीकार्डिया एंड द रेस्पिरेशन विल बी irregular. So this is very, very important. There is raised blood pressure and bradycardia and irregular respiration. Okay, in Cushing's reflex. At what point on this PV loop does the aortic valve open? So if I label this as A, B, C, D, right? So can somebody tell me what is the mnemonic for this pressure volume loop? Very, very important. Remember, it is COCO-MAM. The mnemonic is COCO-MAM. What is this COCO-MAM basically? Closure of mitral, opening of aortic, closure of aortic valve, opening of mitral valve. This is the sequence of valvular events. So this is going to be closure of mitral, right? Remember C-O-C-O, then it is M-A-A-M. This is your trick to remember the valvular events. So closure of mitral, opening of aortic, closure of aortic, opening of mitral. So at what point is the aortic valve opening? It is this point C. Okay. So where this ejection phase is coming in the systole after isovolumetric contraction, this is where you have the aortic valve opening so that the ejection can happen. Is this clear with everyone? Remember, COCO-MAM is your mnemonic. Very, very important. Right? We have discussed all the tricks for how the PV loops change with the various valvular pathologies like mitral stenosis, aortic stenosis, all of that. Okay. What respiratory pattern is characterized by crescendo decrescendo pattern? Crescendo decrescendo. Remember C for C. Cheyne-Stokes breathing. Cheyne-Stokes is crescendo decrescendo. So look at this one. This is crescendo decrescendo, crescendo decrescendo, Cheyne-Stokes. What breathing is this one? Hyperapnea, apnea, hyperapnea, apnea. So this is biphasic jaisa breathing. Remember, biphasic is Biot's breathing. And Kussmaul's that you see like in diabetic ketoacidosis, metabolic acidosis, there is hyperapnea with tachypnea which is happening. Okay, so Cheyne-Stokes is crescendo decrescendo, Biot's is biphasic. Then you have Broca's and Wernicke's areas. Where are they located? Remember the alphabets together. B-I-F, proximal initial alphabets. And for Wernicke's, W-E Wernicke's, remember west. So superior temporal Wernicke's, inferior frontal Broca's. So Wernicke's is superior temporal gyrus. Broca's is inferior frontal. For temporal TT, it is area TT22. For frontal FF, it is 44, 45. FFFF, 44, 45 and TT22. Okay. What is the aphasia in Wernicke's and Broca's? What kind of aphasia? Remember, in both the repetition is lost. Wernicke's is wordy aphasia. Broca's aphasia is broken speech. Broken speech means non-fluent speech. The fluency is affected in Broca's. That is how you remember. What is the active form of thyroid hormone? T3 or T4? Remember, it is T3. Okay, T3 is the active form. Acid-base disturbance at high altitude. Remember, at high altitude, hypoxia, so hyperventilation, that is respiratory alkalosis. Okay, similarly, like you have in pregnancy, hyperventilation. So there is respiratory alkalosis because of hyperventilation happening. Okay. Where is IGF-1 secreted? IGF-1, which mediates the activity of what hormone? Growth hormone. So growth hormone effects are mediated by IGF-1. So growth hormone coming from pituitary, it acts on the liver, right? And it stimulates this IGF-1 coming in. So that is from the liver. Which hormone is inhibited by inhibin? Is it FSH, LH or both? Remember again, F के पास आता है I, FGHI. So FSH is under the effect of this inhibin. FSH is under the effect of inhibin. Right? Next one, boundaries of sarcomere. Sarcomere is sarcomere, Z to Z. Right? So which is the Z line? This one is the Z line, which is in the center of light band, which is I band. Light is I band. The dark band, remember dark is A, that is the A band. So Z is in the middle of the, Z is in the center of light band, which is I band. Okay, so Z to Z is what is a sarcomere. Right? Again, the tricks have been discussed कि contraction में कौन सा same रहता है, कौन सा कम होता है. We have learned the mnemonics for that as well in the physiology sprint also. Which neuroendocrine marker is expressed in small cell lung cancer? Remember, there is chromogranin, synaptophysin. Okay, and in small cell lung cancer, what is the paraneoplastic syndrome that is seen? Remember, small cell lung is SCL. There is SIADH, Cushing's, and Lambert-Eaton. Okay, Lambert-Eaton, SIADH, Cushing's is seen with small cell versus hypercalcemia is seen with squamous. Remember, it as squamous affects the calcium. So, hypercalcemia is squamous and SIADH, Cushing's and Lambert is small cell lung cancer. Okay, azopadi effect दिखता है उसमें. Von Hippel-Lindau gene. Remember VHL, 3 letters. It is chromosome 3. It is associated with RCC. Renal cell carcinoma. What subtype? Clear subtype in VHL. What brain tumor do you get in VHL? Remember cerebellar hemangioblastoma. Okay, hemangioblastoma is what is seen in VHL. Then you have amyloidosis. What stain and appearance? Important, Congo red stain. And there is apple green birefringence. The birefringence you see on not the light microscopy but polarizing microscopy. Okay, polarizing microscopy. Again, Marfan is FBN1, that is fibrillin 1 gene on chromosome 15. Okay, fibrillin 1 on chromosome 15. Then you have in yolk sac tumor, what do you see? Schiller dual bodies, which are also called as, they have glomerulus-like appearance, glomeruloid bodies. Yolk sac tumor is also called as endodermal sinus tumor. Okay, endodermal sinus tumor. How do you remember that, all this? Remember, yes, right? Yes in English is what in Hindi? G. Haan, G. So remember G. So yolk sac is endodermal sinus, Schiller dual bodies, also called as glomeruloid bodies. Versus, what do you see in granulosa cell tumor? Granulosa, what does the excited granny do? Calls her X. So call Exner bodies. Call Exner bodies in granulosa cell. What is the tumor marker for granulosa? Granny excited cannot be inhibited. It is inhibin which is the marker. What is the marker for yolk sac tumor? Yolk sac, fetus ka part yolk sac. So remember, alpha fetoprotein is the marker for yolk sac tumor. Okay, alpha fetoprotein. Then you have Burkitt's lymphoma. What is the clinical presentation given? A child from Africa with jaw swelling, right? Jaw swelling दी रहती है. Burkitt's में क्या दिखते हैं? भर के, Burkitt is भर के stars दिखते हैं. So there is starry sky appearance. What chromosome? Chromosome 8. Remember, Burkitt's B is like 8. Why chromosome 8? Because it is having what gene? C-MYC, not N-MYC or L-MYC. Remember B, Burkitt's के बाद B के बाद आता है C. It is C-MYC gene. So look at this one, starry sky appearance, jaw swelling, and you can have this vacuolated wala appearance of the cells. Okay, this is also Burkitt's lymphoma. Then you have papillary thyroid cancer is the one which has orphan NEI nuclei, right? The orphan NEI nuclei, samoma bodies are seen in papillary thyroid carcinoma. Remember it as papillary is papa, mama, samoma, and there is still an orphan. No papa, no mama, and an orphan. Okay, so it is papillary, has samoma, orphan, NEI, and it has BRAF mutation. Okay, and it has BRAF mutation. Then you have crab is in multiple myeloma. What is a crab in multiple myeloma? Calcium is high. C for calcium, R for renal failure, A anemia, B is bone pain. So elderly patient coming with bone pain, hypercalcemia, renal failure, you think of multiple myeloma, which has Benz-Jones protein urea. Benz-Jones protein urea. What drug do you give in the treatment of multiple myeloma? Remember, bortezomib, which is proteasome inhibitor. Bortezomib. Okay. In tumor lysis syndrome, what electrolyte abnormality happens? The tumor cells are being lysed. So the potassium from inside comes out. So what will happen to potassium? Please remember there is hyperkalemia. Hyperuricemia, the nucleic acid from the cells. Hyperphosphatemia, but there is hypocalcemia. Okay. So there is hyperkalemia, hyperphosphatemia, there is hyperuricemia, but hypocalcemia. Tumor lysis syndrome. ठीक है यस रास्ब्यूरिक एसिड देते हैं हाइड्रेशन करेंगे इन ट्यूमर लाइसिस क्लासिकल अपीयरेंस व्हाट इज दिस टेनिस रैकेट अपीयरेंस these are the Burbeck granules which are seen in Langerhans cell histiocytosis ठीक है LCH Burbeck granules remember L is like 1 it is CD1A positive CD207 and S100 positive S100 is also positive in schwannoma. Okay? In refeeding syndrome, there is hypophosphatemia, which is the first one that occurs. Okay, in refeeding syndrome. What is this one here in the heart? This is Escrow bodies, which has caterpillar cells, which are called as Anishkau cells. Okay, caterpillar cells. So this is seen in rheumatic heart disease. Okay, the diagnosis criteria for this is Jones criteria. Okay, is this clear with everyone? Earliest marker in MI, remember MI में M में M आता है सबसे पहले myoglobin. सबसे last में कौन सा आता है L for L. Last is LDH. First is myoglobin. Specific which is there is TROP-T, TROP-I. Troponin is specific. Earliest is myoglobin. Last is LDH. Okay. PCP has what appearance on the GMS stain? The Gomery methenamine silver stain. Remember, it has P for P, the crushed ping pong ball appearance. Okay, the crushed ping pong ball appearance. PCP pneumonia, common in immunocompromised, HIV positive, bilateral perihilar GGOs is what is given in the question. What is the causative agent of Q fever? Q is Coxella burnetii. Remember Coxella burnetii Q fever, Q for question mark. There is no vector, no rash in humans. Okay, Q fever happening in humans. There's no vector. So how it is coming? It is coming from inhalation, right? Animal contact, livestock wala history, animal contact. वहाँ से inhalation से आएगा Q fever. Q fever is a very important cause of culture negative, infective endocarditis. Okay, it's an important cause of culture negative infective endocarditis. So you do a single serology also positive, that is significant for Q fever. What organism requires factor 10 and 5 for growth on chocolate agar is Haemophilus influenza. Remember, Haemophilus influenza is the one which gets influenced by Staph aureus and it revolves around it like a satellite. So influenza, it what shows satellitism. Okay, Haemophilus influenza is what shows satellitism. Very, very important. Which organism causes multiple painful ulcers and also the inguinal lymphadenopathy is tender? So the patient is crying because there is so much of pain. So remember, crying wala is caused by do cry. Patients do cry. Okay, so Haemophilus do cry causing chancroid. Okay, that is chancroid. What appearance does it give? Kids going to school do cry. So school wala appearance, school of fish appearance is what you see with hemophilus do cry. So painful ulcers, which are multiple, and the buboes, the tender inguinal lymphadenopathy. Very good. Parvovirus B19 is what has the slept cheek appearance. What is that called as? Erythema infectiosum, right? The fifth disease, erythema infectiosum. And remember, parvo is a DNA virus. Parvo, parvo single-stranded hai. Parvo single-stranded hai. So, which is a single-stranded DNA virus? Parvo. Parvovirus is single-stranded DNA. Plus, what does it cause? Aplastic crisis. Okay, aplastic crisis. Non-immune hydrops fetalis is what it causes. Vector for Kala Azar and Lyme. We have learned the tricks for all the vectors. Kala Azar. Remember, Kala is the hair, black hair. Hairy vector. It is the sand fly. For Lyme disease, remember the rhyme for the Lyme, that is hard tick wala, had a rhyme which had Lyme. Okay. So what was the rhyme for the hard tick? Baby to a hard tick, 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 hard like a rock, tick, 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 right? So babesiosis, tularemia is hard tick, rock is the Rocky Mountain spotted fever. So that was hard tick. Okay. So remember, it is Lyme is rhyme of hard tick. Okay. So that is hard tick. Classical image India ink stain, that is going to be for Cryptococcus. Okay, another stain used for Cryptococcus is Mucicarmin. Remember C aa raha hai, that is for Cryptococcus. India ink. Why India ink? Because it is used for capsule. So Cryptococcus is an encapsulated yeast. Okay. So it is India ink stain is used for Cryptococcus. Cryptococcal meningitis. Remember, primary is the lung where the Cryptococcus comes, and then it can go in immunocompromised to the brain. Cryptococcal meningitis, what do you give? Amphotericin B plus, fluconazole or flucytosine. The induction phase is flucytosine, and then in the maintenance phase comes fluconazole. Okay, in the maintenance phase is fluconazole. Is this clear with everyone? Yes? Everybody is with me? A quick thumbs up if you're getting all of this, right? A quick last minute revision. Very good. Going to this one, what parasite is this which has a terminal spine like this? Remember, terminal spine TT is seen in Hematobium, not Mansoni or Japonicum. So Hematobium has a terminal spine. Hematobium BU affects the urinary bladder. It causes the what cancer? SC causes SCC, squamous cell carcinoma, not the transitional carcinoma of the urinary bladder. Then you have, when there is chronic kidney disease, anemia, what do you give for treatment? Erythropoietin ka bhai, darbepoetin. Okay, darbepoetin. When you give chemotherapy, if there is thrombocytopenia, then what do you give for treatment? Oprelvecin. Right? Remember, oprelvecin is used for OP. OP is 0P, that is 0 platelets जब हो रहे हैं तब oprelvecin. जब RBC anemia हो रहा है तब darbepoetin. Okay, then you have filgrastim, samogramostim, all of that. Central diabetes insipidus, what is the treatment? When it is central, that means the hormone itself is deficient. So you give hormone replacement for ADH vasopressin, that is desmopressin. Okay, so then you give desmopressin. Versus when it is nephrogenic diabetes insipidus, then what do you give? Then you give thiazides. Okay, then you give thiazides for nephrogenic diabetes insipidus. Next one, fluoroquinolones are associated with tendinitis and rupture. Okay, remember, fluoroquinolone antimicrobials, they take the patient to the floor. The patient falls on the floor because Achilles tendon is getting ruptured. So fluoroquinolone take the patient to the floor. Okay, so that is tendon rupture. Drug which is used preoperatively when you are operating for pheochromocytoma, so to stabilize the blood pressure, you give phenoxybenzamine. Alpha blocker is given first, phenoxybenzamine. Finasteride, which is used in the treatment of BPH, how does it function? Remember, finasteride, it is the reductase which it is inhibiting. 5-alpha reductase. It prevents the conversion of testosterone to 5-dihydrotestosterone, which is the active form. So it is used in BPH, prostate cancer, to prevent the growth of cancer cells. Okay. CML और GIST में कौन सा tyrosine kinase inhibitor यूज करते हैं? Imatinib. Okay, imatinib first line drug for CML. Okay. Yes. Drug of choice for PSVT. Remember, first of all, in PSVT, what do you have? There's tachycardia, the rhythm is regular, and the P waves are absent. You see this narrow QRS complex because it is supraventricular tachycardia. So, narrow QRS in supraventricular, broad QRS in VTAC, ventricular tachycardia. So, this is tachycardia with narrow QRS complex, regular rhythm, but the P wave is not seen, PSVT. The drug of choice is adenosine. If the patient is unstable, then you directly go for cardioversion. Before giving adenosine, you can do the vagal maneuvers and then you can go for adenosine. Okay, like carotid massage. Ethosuximide inhibits what type of calcium channel? Remember, ethosuximide, T for T, it is T-type calcium channel, T-type in the thalamus, in the brain. It is used for absent seizures. Okay, it is used for absent seizures. How does methotrexate act? Methotrexate inhibits DHFR, dihydrofolate reductase. What is the mechanism of action of digoxin? It increases the heart contractility. That means it increases the calcium. How? By inhibiting sodium potassium ATPase. Okay, so that is how it increases the calcium. Does it decrease the mortality in heart failure? No. Remember, it is not decreasing mortality. Drugs decreasing mortality are acting on sympathetic system and RAS system. So you have beta blockers, you have ACE inhibitors, you have spironolactone, which are decreasing mortality but not digoxin. What electrolyte abnormality is important for precipitating digoxin toxicity? Remember, hypokalemia. Hypokalemia increases toxicity of digoxin. Okay? Yeah. Sulfonylureas used in diabetes, they increase the insulin release from the pancreas by acting on what channels? Potassium channels, they are blocking or opening. Remember, they block. They are potassium channel blockers, not openers. So by blocking the potassium channels, causing depolarization, calcium coming in, they cause the insulin release. Okay. So remember, sulfonylurea, SU, they cause the surge of insulin coming from the pancreas by potassium channel blockade. Cyclophosphamide CY causes hemorrhagic cystitis, and you give Mesna to prevent this hemorrhagic cystitis. The toxic compound is ecroline, causing hemorrhagic cystitis. Opioid poisoning, morphine poisoning. Remember, there are 3 C's. There is constriction of pupil, coma state, right? And constipation is there. It classically causes respiratory depression, plus it causes constipation, right? So remember, constriction, coma, constipation, these are seen with opioid poisoning. What is the drug that you give in acute overdose? That is naloxone, not naltrexone. It is naloxone in the acute treatment of opioid toxicity. Okay? Lucid interval is commonly seen in lucid. Write it as lucid, ED. It is seen in EDH. Lucid interval is seen in EDH. Right? Is this clear with everyone? Next one. Fluorosis is basically because of excess fluoride. So what technique do you use for defluoridation? What technique is used for defluoridation? What is the name of the technique? Nalgonda technique. Okay, Nalgonda technique. And what do you use in Nalgonda technique? Just give me a minute, guys. Just a minute. All right. Am I audible and visible, guys? I can see the confusion in the chat for flumazenil and it is fomepizole. ठीक है. So remember, flumazenil वाला जो होता है, flumazenil. Remember, flumaze is for diaze. It is for diazepam, benzodiazepine. Okay, that is diazepine. And then you have fomepizole, which is for methanol, methyl alcohol, right? Methanol poisoning, वहां आएगा fomepizole is methanol and flumazenil is benzodiazepine or diazepam. ठीक है, right? So Nalgonda technique में क्या substances use करते हैं? Remember, it is lab. There is combination of lime plus alum plus bleaching powder, which is used in Nalgonda technique. Okay. Then you have, what is this Pearl index used for? Contraceptive efficacy. The failure of contraceptives is evaluated by Pearl index. So basically it depends on the number of accidental pregnancies upon the total women months of exposure. How many months of exposure? So let's say that in the questions they give you that 20 women take the contraceptives for 5 months and another 20 take the contraception for 8 months. Then what will be the denominator in that case? 20 into 500, 20 into 8, 160. So total it becomes 260 months, women months of exposure, and you multiply it by 1200. Okay, and you multiply it by 1200. So that is Pearl index. The Weber-Ferguson incision. Remember, ऐसा आता है Weber-Ferguson incision, which is used for maxillectomy. Okay, that is used for maxillectomy. So if this is the phase, यहाँ पे ऐसे आता है Weber-Ferguson incision. So remember, W Weber ulta M. This is used for maxillectomy. Okay, right? What color code in triage is used for immediate life-saving intervention required? Remember, it is red. So you have red, yellow, green. Red is immediate, green is ambulatory. And what is for moribund or dead patients? Dead moribund patients is black color, right? Kali zindagi, nothing will help now. So that is moribund. Immediate one is going to be red. Then you have Zenker's diverticulum, upper esophagus, elderly patient with triad of halitosis, regurgitation, dysphagia is Zenker's. Coming in the inferior constrictor, which has thyropharyngeus, cricopharyngeus. So it is in the inferior constrictor between thyropharyngeus, thyroid cartilage, cricoid cartilage होता है. So thyropharyngeus, cricopharyngeus के बीच में आता है. Killian's dehiscence, वहां पे होता है Zenker's. Zenker's is an anterior diverticulum or posterior? Remember, it is a posteriorly directed diverticulum. It's a false diverticulum. Okay. Pituitary adenoma, classical visual field defect. Related to pituitary is the chiasma. So that is going to cause bitemporal hemianopia. What are you seeing in this case? Is the suprasellar lesion, which is craniopharyngioma. Even that causes bitemporal hemianopia. Keratoconus, what investigation will you do for keratoconus? Kerato matlab cornea, becoming cone-like. So you want to see the surface of the cornea. So corneal topography. Okay, not keratometry. It is corneal topography. Pachymetry is for thickness. If there is a phenotypical female, but the genotype is XY and there is primary amenorrhea, right? And there is absent uterus, then you are thinking of androgen insensitivity syndrome. Remember the mnemonic here, which is auspicious time is the AM time, right? Amrit Vela, auspicious time is the AM, the morning time. So absent uterus, secondary characters like breast present in AM. What is AM? Androgen insensitivity and MRKH. The difference is the karyotype. Androgen is male wala, 46XY. This is Mullerian duct in female. This is 46XX. Okay. So remember, that's how you differentiate. Okay, that's how you differentiate. PCOS ultrasound shows the classical string of pearls appearance or the necklace sign. Okay, PCOS, PMOS. Magnesium sulfate, which is used in severe preeclampsia, eclampsia. The toxicity of that, very, very important. What is the first thing? It is loss of deep tendon reflex. So there is loss of knee jerk reflex that you see. There is decreased urine output. There is respiratory depression. But the first thing is the patellar reflex being affected. Placenta previa versus abruptio placenta, both presenting with antepartum hemorrhage. Remember, classical placenta previa is painless, right? Suddenly overnight when the patient wakes up in the morning in the gush of blood, while abruptio placenta, where like the placenta is getting separated, there is the hemorrhage behind it, separating the placenta, that is painful. Okay, so what they will give you in the question, the uterus is tender, woody uterus, that is going to be abruptio placenta. It has increased risk of DIC. Okay, there's increased risk of DIC, right? Tetralogy of Fallow, remember, has boot-shaped heart. Boot is Corin sabut, sabu. Okay, it is seen because of RVH. It is seen because of RVH. Is this clear with everyone? What are the four components in tetralogy of Fallow? Remember, it has proof, pulmonary stenosis, RVH, overriding aorta, and VSD. Remember, it is not ASD but VSD. So these are the four components of tetralogy of Fallow. Right? What is the intravenous IV induction agent of choice for daycare surgery? It is propofol, because remember, propofol decreases the vomiting as well. Okay, it does not increase vomiting, it decreases the vomiting. It's an oil-based injection, so it can be a painful injection as well. ECG finding of hypokalemia and hyperkalemia. What are the ECG findings in hypokalemia and hyperkalemia? Yes. Remember, potassium is what is responsible for repolarization. Ventricular repolarization is given by T wave in ECG. So potassium affects first the T wave. When the potassium decreases, T wave decreases. Potassium increases, T wave increases. So where will you see tall tented T waves? When there is more potassium. So that is hyperkalemia. Opposite, T wave decreasing. So after that comes the U wave. That becomes prominent in hypokalemia. Remember, it as UK. U is for U. UK. U wave is seen in underkalemia. That is hypokalemia. So always remember this, a very handy mnemonic which helps you. UK, underkalemia, has U wave. Okay. So look at this one. What are you seeing here is the U wave, hypokalemia. Tall tented T wave, hyperkalemia. Okay. Next one, most specific ECG sign in pulmonary embolism is the S1Q3T3 pattern, also called as Mc-Ginn-White sign. Okay, S1Q3T3 pattern is pulmonary embolism. This is most specific. Most common is tachycardia, sinus tachycardia, that is seen. Okay. WPW syndrome, which has the accessory bundle of Kent, which transmits the signal from the atrium to the ventricle, right? So remember, what are the ECG findings of that? The PR interval is short, not long. There is delta wave present and there is broad QRS. Whatever excites a ventricle from abnormal pathway, the QRS becomes broad. Okay, so there is delta wave, short PR interval, and a broad QRS complex. Remember, it's a short PR interval, not long, and there is delta wave seen. Okay. Then you have Beck's triad, which is seen in cardiac tamponade. Okay, Beck's triad. So what are the three things in the Beck's triad? Remember, it has vein draining into the heart and from there coming the artery. So vein wala, raised JVP. Heart wala, muffled heart sounds. Artery wala, decreased blood pressure, hypotension. So high JVP, muffled heart sounds, hypotension. This is classical of cardiac tamponade. Versus in pneumothorax, what will happen? The breath sounds will be absent. In tamponade, the heart sounds, because it is surrounding the heart, pneumo is surrounding the lungs. So heart sounds versus breath sounds. Okay. And remember, in cardiac tamponade, how is the JVP pattern? The JVP waveform. Remember tamponade, TA, is like paying increased tax. Paying increased taxes, but there is no why. There's no reason for it. No why to it. Why am I paying more taxes, right? That's what happens in India. So remember, X is prominent, but the Y is absent in tamponade. The Y is absent in tamponade. Okay. Classical presentation of subarachnoid hemorrhage is worst headache of life, and it is due to rupture of berry aneurysms in the circle of Willis. In subarachnoid hemorrhage, you will see the CSF, which is replaced by blood on CT. So that's where you see the blood, the white blood in the fissures, in the cisterns, in the center, giving the star of death appearance. What calcium channel blocker do you give specifically in subarachnoid hemorrhage? That is nimodipine. Very important. That is nimodipine. So remember, like Nemo, patient Nemo gets subarachnoid hemorrhage. So nimodipine in SAH. Radiological sign in intersusception. Remember the C and the C, the claw sign and the coil spring sign. This is where you are seeing this claw sign. Remember the target sign, which is seen in intersusception, inner bowel, outer bowel, that is seen on USD or CT, the cross-sectional imaging, while this is seen on barium enema. Okay, this is seen on barium enema. The classical clinical finding in intersusception is going to be red currant jelly stools. Okay, that's going to be red currant jelly stools. The management first is pneumatic reduction, air enema. Okay. EDH classically comes, ED is idly shape, that is biconvex shape, like you see here, does not cross the sutures, right? It is due to rupture of middle meningeal artery, which is related to pterion, right? Pterion kya hota hai? Middle meningeal artery. It is biconvex shape. Then you have ureterocele, ureter coming and dilating like a seal, like a pouch. So this is cobra head appearance. So ureter coming and dilating like the cobra head. So remember, that is adder head or cobra head appearance is seen in ureterocele. Okay, that is seen in ureterocele. Is this clear with everyone? Yes? No, Abdul, this is not just one subject. These are just hand-picked important topics, the flashcards from all the subjects mixed together based on what is frequently asked in the exam. Okay? So that was about the today's session, guys. There is much more, many more topics that have been discussed there are free final punch 8 videos available on MedSynapse app. In the PDF, I've given you the link. You can go to the MedSynapse app. There you can go in the free content wala tab, and you will see the final punch wala folder, which has all these videos present there at one place, right? Even this video you'll be able to see in the app along with the blank and annotated PDF attached to it at one place itself. Okay. And for others who are planning for appearing for future exams, if you have aspirants for NEET PG 27, FMG December, right, we do have the entire short extra edge course on MedSynapse app. We have various subscriptions available at very, very affordable price. So you can go through it and definitely get a boost in your scores and ranks, right? So that was about the quick today's session, guys. Yes. And I hope this helps you in your last minute revision and you definitely see questions out of this in your upcoming exam. So thank you so much for joining in. Do go through the PDF quickly. And tomorrow we have all the best wala session, the exam all strategy session for FMG exam. That's on the YouTube channel, Prep Ladder's YouTube channel, tomorrow at 5 p.m. So you can join in there. Okay, so thank you so much, everyone, and all the best for your upcoming FMG exam. Would be definitely waiting to hear from you post exam. The most important thing now is please stay relaxed. Okay, remember, it's just one exam, which is not equal to life, right? So take it as easy as you can and do not worry about it. Have the faith. Okay, all the best and stay blessed always. Thank you.